So good morning, everybody. We would like to start our Acquire QI for Leadership Forum. And I know there are others who have joined us online. Welcome. So I'd like to take this opportunity to, I don't know whether, are there people who are outside who can, so that we can whip everybody to come in so that we can start together. So welcome for those who traveled yesterday. So this is our moment when we come and reflect on quality improvement issues, particularly in Africa, where we want to see what can we do to enhance health outcomes. And it is, we have here a gallery of experts who are here so that we can come and sort of like reflect, look at where we are as Africa, and see what can we do, how can we now mainstream or institutionalize quality of care in Africa. So without much ado, I'd like to take this opportunity to welcome Ruth Pearl Nganga from Acquire to make her welcome remark. Karibu.
Good morning, everybody. Tevin, I'm hearing feedback. Something isn't quite right. But what a pleasure, what a joy to have all of us here this morning. Right in the middle of the year, we are having an opportunity to have what I think is an opportunity to share and learn together. My name is Ruth Pearl Nganga. I'm one of the Acquire co-founders. We call ourselves a trio of ladies with a good idea. And each one of us will share a little bit, I think, through the day of how this good idea began. But more than that, I think how you are going to contribute to that good idea. So my background is not medicine. My background is actually communications work. I help systems function in different ways. I'm actually doing it in agriculture, in the agricultural space, with the African Union and other partners, and I also do it here. I'm interested in making systems work. How are people working together? Are the right stakeholders having the right evidence? What is influencing our decision making? What is the bottleneck to efficiency? So getting the entire system to work is the background of how I landed in Acquire. I remember how this story started. It was Mary Adam, the other co-founder, called me up towards the end of 2019 and said, there's this opportunity to put a grant together. There's this idea we've been having about helping frontline healthcare workers. Why don't you and I put this together? Then when we started, we realized, we need a lot of partners in quality improvement. And so she called Lydia, and we spent the beginning of 2020, January and February, writing this fantastic proposal. It was a grant proposal, and saying, if we were to get frontline healthcare workers to learn from each other on quality improvement, what would it look like? If we were to give them the skills, what would it look like? And it was a lot of big dreaming. Let me not even be shy and tell you, it was a $10 million proposal. We started with ambition. So we put that proposal in, we submitted it on February 27th, and I think the adrenaline, the joy of thought leadership and ideology, we were like, oh my, this is such a fantastic idea. Maybe it shouldn't be just a proposal. Maybe we try and begin to implement these ideas. And so as we progressed on through the year, of course, 2020 allowed us to think differently about our work and the work we were doing. And so we said, we got a chance to submit a second round, but we missed it on the third round. And you know, I know Mary might take a moment talking about how it was so frustrating because all the reviewers said it was a fantastic idea. But the main reason they didn't give us the money was that they couldn't identify reviewers on the continent who could offer the thought leadership support to the work we were doing. And we're like, but we are trying to grow them. How can you refuse us for the main reason? And it was one of those things that made us begin to think again. And so we began to work with institutions in this country through 2021, through 2022. We've had the chance to do quality improvement trainings with you. We've had a chance to do them virtually. We've had a chance to do them face to face. And it has been a wonderful experience. Just this year, we have had, I think, about 750 different people participate in the Acquire Quality Improvement IHI virtual program. And we'll be talking a little bit about that as we go. I know Dr. Tumi, Dr. Nora, Dr. Edna are all here and are going to be sharing a little bit about that. You know, the thing that we really hadn't had a chance to do was bring you, the leaders, together to have conversations about what is it that quality improvement, what is that the quality improvement and patient safety space needs? Who is it we need to bring together? What are our capabilities? What is the status now? What does progress look like? These are all the conversations that we hope to have with you this day. We are very, very grateful for this opportunity. We hope that this QI Leadership Forum becomes an annual event, and that before we know it, it'll actually be a country, it'll be an Africa-wide, not just Kenya event. I want to even acknowledge that we are having participation from 8 different countries in this room, and I think as we go through the day, we'll have a chance to know who else is around the room. But for now, I simply just wanted to ensure that you feel welcome, that you are sure that this is the right place to be. I also want to acknowledge those that are online. I think you might be more than the ones in the room. We will be paying attention to you, reading out what you're saying, giving you an opportunity to talk. This is a genuine hybrid event, and it's a genuine opportunity to really practice the approaches that we champion in quality improvement. So allow me to say welcome, and I will hand it back over to Dr. Kandie, who will invite Dr. Kamau Irungu, who is speaking to us online.
Another round of applause for Ruth Pearl, for that's why we are here. So thank you very much. I'm Dr. Charles Kandie. I work in the Ministry of Health. I'm in the Directorate of Health Standard Quality Assurance and Regulation, and I'm a lead head for cluster of quality improvement in the Ministry of Health. So we sort of like the inspiring counties and health facilities in the country, both public, private, and FBOs to embrace quality improvement. So without much ado, I don't know whether the program has changed, but I know we were to have a keynote address by Lauren De Kock. I don't know whether that is, or we can ask Dr. Irungu maybe to take the opportunity now. So let's, so as I wait for guidance, welcome. So, Dr. Irungu, who is online, I don't know whether you can hear us. We will be asking you to give your keynote address. So, Dr. Irungu, are you on the call? You can unmute and talk.
Yeah, thank you. Thank you so much, Dr. Kandie. As introduced, my name is Dr. Irungu Kamau. I work in the same division of quality assurance, but I head the unit responsible for patient safety, IPC and AMR. And on this session, I'm standing in for Mr. Thomas Gachuki, who is the head of our division. I know he has a presentation, but specifically for this introductory session is for him, he wishes to state that the MOH is committed to delivery of quality services, and there have been quite a number of initiatives put in place by the Ministry of Health in regard to ensuring that quality service is delivered. This stems from the fact that up to about 8.6 million deaths per year occur and can be attributed to inadequate access to quality care. And up to about 3.6 million people who did not actually get the access here. And in Kenya, up to about 52,000 deaths will be attributable to poor quality care. The Constitution of Kenya has stated that everyone has the right to the highest attainable standard of health, which includes the right to health care services, including reproductive health care. And therefore, the Ministry of Health is committed to ensure that quality of care is delivered and that care that is given is effective, is safe, is people-centered, is timely, equitable, integrated, and efficient. And for this fact, there are several, as I stated earlier, measures that have been put in place. And the division is proud to have put in place what is called the Kenya Quality Model for Health, which is a conceptual framework for an integrated approach to improve quality of healthcare, which holistically and systematically addresses a range of organizational quality issues with a whole aim of being able
Dr.
to deliver positive health impacts.
Dr. Kamau, we are not being able to see your presentation. Are you able to share your screen?
Sorry, in a minute, yes, sorry.
You have not shared your screen, so we are not following your presentation.
Oh, sorry, I think there was a small error, so I hope my screen is visible now.
Yes, we can see it. Thank you.
Yeah, sorry, yeah. So, as I stated, initially I was just do on behalf of the head of the division. I had not been, I don't have maybe to have this presentation now, but I just ran through the key elements of this presentation. And I was at the point of stating that the Ministry of Health is keen to deliver quality of care based on the 7 strategic areas of quality, effectiveness, safety, people-centeredness, a healthcare that is delivered in a timely manner, equitable, integrated, as well as efficient. And we know that to achieve quality and patient safety, it cannot be assumed to be an accidental, but rather a deliberate process, which is driven by policy and strategy. And the quality improvement journey, as aligned to our Kenya Quality Model of Health, of course, starts from the point of registration and like
Thank you very much. Let's give another round of applause to Dr. Lauren De Kock, who is a passionate and internationally recognized quality improvement specialist and author. Her unique experiences in the field of QI has provided many opportunities to design and lead quality improvement programs at small and national scale. She's a regional director for QI and training at Aurum Institute. She is also currently seconded to the South African National Department of Health, HIV, AIDS, and STI cluster as the operational Fortuma QI lead. In this role, she's responsible for designing and implementing a national QI approach to address the shortfall in the UNAIDS 95-95-95 targets. Her unique ability to teach, mentor, and lead in the field of QI allows her to work with all levels of government across the country to drive sustainable change. So let's welcome her with a round of applause. So, karibu. Welcome.
Is it being projected, or do you need to plug in my laptop? As you can see, we're all in need of a bit of quality improvement, aren't we? Good morning, ladies and gentlemen. Jumbo, it's nice to be here with you, and I'm honored to be at this podium and to share these 2 days with you. As I was introduced, my name is Lauren De Kock, and I'm from the Aurum Institute in South Africa, but also most of my time is spent rolling out a quality improvement initiative in the HIV program for the National Department of Health. So this morning I was tasked with a very onerous job to talk about quality improvement globally and what can Africa do. And I thought in the few minutes that I've been provided, I will surely not give that subject its due honor that it needs. So I've tried to touch on a couple things where I see the problem with quality improvements in Africa, and what is it that we need to do about it. So we all know, and I'm not going to go into the definitions of quality improvement, but I think what I want to highlight is that it aims to increase the likelihood of desired health outcomes. And I think that that's important to realize, that in the world of quality, we must be very clear of what our aim is. We need to increase the likelihood of desired outcomes. Next slide. So where are we globally? Between 5.7 and 8.4 million deaths are attributed to poor quality care each year in low to middle income countries. That's 15% of the overall deaths in these countries. 60% of deaths in low to middle income countries are from conditions requiring health care can occur due to poor quality in care. Staggering figures, 60% due to poor quality in care. Inadequate quality of care imposes about $1.4 to $1.6 trillion each year in the loss of productivity. So let's have a look at a South African scenario. Let's bring it a little bit closer to home. Even though we can see that globally, there is a massive problem. Have a look at our HIV problem in South Africa. Sorry, I don't now have the slides in front of me, so I can't see the exact numbers. Can we go back, please? Okay. Sorry. So globally, the essential structures for achieving quality care are inadequate. 1 of 8 healthcare facilities has no water service. 1 in 5 has no sanitation, and 1 in 6 has no hygiene facilities. How can that be in an era with artificial intelligence, where cars are being driven by themselves without a human being, that we can still sit with a clear conscience by saying that we don't have running water or electricity, or that patients are not receiving the care, or they're receiving harmful care? So let's go on then to a South African scenario to see what does that play out in stats. If we have a look at what's been displayed here, we have a cascade to be able to show of those that we know who are positive, who are receiving care, who are getting the viral loads done, versus how many of those are suppressed. And because I can't see it very well in front of me, you will see that as that cascade goes down, we are losing thousands of patients. And so those who are actually needing viral loads done are not getting them done. And then those who actually have them done and then become virally suppressed, even a smaller percentage of those then become virally suppressed. So we have a major problem here, ladies and gentlemen. Next slide, please. When we went, our lives, I think, at the moment seem to be pre-COVID, post-COVID. And we recall memories pre-COVID, post-COVID. And people keep talking around what is the next crisis in the health system? What is it that we need to be preparing ourselves for? Well, I believe the crisis is here. I don't believe we have to wait any longer. The crisis to me is healthcare, is the delivery of healthcare, and that our health systems within Africa are crumbling. And so we no longer need to wait, but there are certainly things that we need to do to address the crisis. Now, how do I define this crisis? I want to identify 7 things that I feel are a crisis in which that we are dealing with. You can go to the next slide. The first thing is that we are not seeing ourselves as a health system. We do not design health systems. We design programs. And in that lies a problem, is that we are not seeing the interconnectedness of our health systems. Next slide, please. Our health systems are often designed out of necessity, out of adaptation from a crisis, and we are not deliberate and mindful in our implementation. As a result, this causes silos and it causes confusion within our health systems. Health systems tend to evolve over time in order to survive. And so that deliberate planning about how work is to be done is not there. Next slide. So can we truly design our health systems? Absolutely. Let's give you a basic example. The example that I have in front of you is about how can we get more people to test for HIV when coming into the clinic. When looking at the design and the flow of patients that come into clinics, what do we see? Push. Slide, please. We see that many patients were coming into the consultation room. From the consultation room, having seen a clinician, they were then requested to go and have an HIV test. Next slide. But what could we do? Because when they are requested to go to another queue, to go and wait in another line to see another healthcare practitioner, they leave the clinic. Why should I do that? And so by simple redesign, by first coming to an understanding that healthcare is a system and that it can be designed, we can redesign our work so that we can get better outcomes. So now, instead of losing patients, we are actually gaining patients, and we are giving them the critical care that they need. Next slide. We need to think very deeply about this saying, this quote that's in front of you that says, every system is perfectly designed to get the results it gets. If we keep looking at our data month after month, quarter after quarter, and year after year, and we see very little change or it starts to look the same, we have to realize it's been designed that way. It may not have been a deliberate design, but the design of our healthcare systems are producing outcomes, are producing results. And so we have to attach a systems view to how we are doing our work if we are to redesign it for success. Next slide, please. Could we ever have success in a system that looks like this? I don't believe that that is an unusual sight. I believe that it is something. I've been to many countries across Africa, and as I visit clinics, I see the same sort of problems. How could we truly be designed for success when we don't even take care of our patient records? Where our patient records, next slide please, create duplications. We've done a number of studies across South Africa where we've gone through file sorting processes to be able to see what is the impact of this disarray that we find. Some of these things I've got in front of you, just have a look, because when we've gone to some of the facilities and we see how many duplicates do we find. We are seeing up to 3,000 duplicates in one facility. That doesn't just talk about a duplicate of a file. It's duplicate, it's waste in the system of bloods and effort that has gone into managing patients or finding files and then simply creating blanks. And then we create these blanks that have no history in them. You'll see that when files are collected, we find many that are lying around in the pharmacy. We find clinicians holding onto files in their desks, and we find files unattended in bathrooms and kitchens and other places around the clinic. This is unacceptable, and this is designed for failure. We cannot have a health system where we can't even manage our health records. Next slide, please. So the next problem that I want to talk about in Africa is the fact that we work in silos. And what is the repercussion of the silos? Next slide. This graphic representation in front of you shows some of what I'd like to emphasize about what are the repercussions of working in silos. This graphic may seem simple, but take a look at where our efforts are where we are focusing our efforts. Most of the efforts have focused downstream, where we are not trying to understand the cause of why people keep falling into the river. And so we send people emergency services downstream to keep pulling them out. There is not enough focus in our health system on the cause of the problem. One of the reasons being, going back to the first point which I noted, of the fact that we are not working in health systems. It's difficult to identify the causes of problems when we work in complex systems. It is not as simple as people think. We don't just see the causes, we have to investigate the causes. Look how badly designed this health system is. The people who are doing the rescuing are pulling the people out on the left-hand side of the river. But where is the ambulance that's going to be transporting them to the hospital? On the other side of the river. So what do we do with those patients now? Now we've pulled them out, now we've got to get them back across the river. These are some of the small things that we need to pay attention to, and that working in silos creates. Working in silos creates that waste in our system where we are not perfectly designed for success. Is that we are wasting our efforts in designing pockets of what may be excellence, but pockets of good services that are not actually truly meeting the demand or meeting the desire of the patients. Next slide, please. Number 3, QI is not my job. I believe that this is a crisis in Africa, because we have become very donor-funded reliant. And with that donor funding comes expectations. With that donor funding comes with all sorts of data collection, ways in which we perhaps weren't working before. And we have created silos in our health system based on the money in which we receive from donor funding. And what it has done is it has shifted blame of quality improvement that no longer seems to be my responsibility or the Department of Health's responsibility in our respective countries, but it has taken on the responsibility of those funders and the people that they are funding. I love this quote by Paul Batalden, which says, it's a part of the quote, which says, healthcare will not realize its full potential unless change-making becomes an intrinsic part of everyone's job, every day, in all parts of the system. Defined in this way, improvement involves a substantial shift in our idea of healthcare, of our idea of work. Healthcare and quality improvement in healthcare and patient safety cannot be outsourced. It must be owned by those who own the health system. It must be led and guided by those who own the health system and those who work in the health system. I believe as countries in Africa, we do need to take a greater stand to ensure that our efforts are far more integrated, that we work far more in multidisciplinary teams and integrate our problems so that we address the health system and stop just being disease-focused. The disease focus has created the silos in our system, which has created the opportunities for patients to come to our health clinics and not receive the services that they require. Next slide. Carry on, please. So what is that shift that we need to make? We need to shift the way in which we do our everyday work. We need to shift the way in which we see improvement and the way in which we see patient safety. That is not something that can and must be outsourced. It is our job, it is everyone's job that works within a health system. We must do our jobs, but we must do our jobs better. That is our responsibility. And so working in those silos and creating pockets of excellence that is often ruled by funding or uncoordinated demands is creating the silos in our system and creating inequality in our system. Next slide, please. Let's have a look at number 4. The fourth big problem that I see in Africa is the way in which we use data. Next slide. We have a lot of reporting systems in place. Often, what we do is dictated by those reporting systems. The problem is that we lose ownership when we simply report. We are not using data for improvement purposes. We need to look at cascades like the one that's being projected in front of you to help us to understand where our problem is, where the biggest problem is, who we need to focus our efforts on. How are we progressing over time? Next slide, please. We need to be able to understand that over time, are we getting better? Are we getting worse? As we see in the first 6 months of care, as we compare data over 3 years in South Africa, we are losing more patients in the first 6 months now than what we did 3 years ago. Next slide, please. Next. We also have to begin to look at data differently. Next. We all too often look at just simply quarterly data that, again, next please, and again, that does not tell us about the functioning of our health system. The graphics that you have in front of you on the left-hand side is a bar graph with exactly the same numbers of the 4 line graphs on the right-hand side. All of them having exactly the same numbers, but all, ladies and gentlemen, telling us a different story. So why is it important then for us to know the story that our systems tell? Next slide. Is because it tells us about how we need to act. We are not collecting enough data about how we are working in our health systems. Outcome data that we obtain from our DHIS or from other health systems is not giving us enough process data as to how we are working. So if we are to make that shift into doing what we do and doing it better, we need to collect data in different ways. This is a simple example where we looked at data from the different entry points. So if people were coming into the clinic, we had to compare them from how many patients were booked versus how many landed up in the different data points that are recorded in our clinics. And you can see that actually when we had 163 patients, we ended up with only 74 that were registered at the end of the day. How did we lose them over time? And the reason why we must know is because they were all lost in our facilities on that day. And in order for us to address it, do I need to look at the way I'm booking? Do I need to look at the way I'm capturing? Do I need to look at my headcount register, or do I need to look at my tier.net or my DHIS? All of those represent opportunities for improvement, but if we are not collecting data for improvement purposes, we will never know where we need to intervene. Next slide, please. So if we take a simple example of viral loads, if we attach a reporting lens to how we look at our viral load management, simply we will say we need to improve data capturing. And the responsibility will fall on data capturers. If we take a more improvement lens to our data work, we will realize that there's a lot more to improving our viral load management than simply data capturing. We need to ensure that all of those who are needing a viral load actually know that they need the viral load, that they've been contacted, that they return. We need to make sure that it has been done. We need to make sure that it has been suppressed. And we need to make sure that the results are flowing from our labs back to our facilities, and that it has been well recorded and put back into the patient's records. That involves a team effort. It is no longer just the problem of the data capturer, but it involves various people within our systems. And so when we attach a systems view to our work, it changes how we collect data, how we use data, how we analyze data, and how we present data. Next slide, please. Number 5. I've been concerned for a long time about the type of management support that we provide our healthcare service delivery clinics and hospitals. I believe that as managers, we are spending a lot of time trying to enforce a law. We are spending a lot of time simply doing audits when we are not spending sufficient time in creating a health system that is well designed to help us to achieve what we need to achieve. We are not spending enough time mentoring. We are not spending enough time helping people to understand their problems and then identify ways in which those problems can be addressed. Working at a management level, whether it be at a district or a province or a national level, you can see various ways in which problems can be addressed that people stuck in a facility every day cannot see or even have access to. Our responsibility as management is to unlock those barriers. Our responsibility of management is to ensure that we are creating environments that are far more conducive to improvement than simply doing the audits to say that I've done. We need to stop managing from behind our laptops. We need to stop managing with books in our hands and going to clinics in order to create the fear of God in people. We need to manage so that we feel and that they feel that we are a collective part of the problem-solving solution. It is our problem, it is not theirs. Next slide, please. In South Africa, we have an ideal clinic standards. And if you had a look at the previous viral load data I showed you, we've got a serious problem with viral loads in South Africa. When we simply look at the standards within our ideal clinic, you would see that it's looking pretty good. Everywhere else is green except one little poor facility there. We cannot simply just be standards focused. The standards have to lead to an improvement in our health systems. One of the favorite quotes that I love, and I can't remember who the author is, and I looked for it last night and couldn't find it, was if you give people a target, they will reach it every time. When you create an audit-driven environment, people will meet their targets even though the data is telling us something else. There's a disconnect in our health system when we simply are chasing the target. If we do not get that data that talks to us about how the health system is functioning, we will have targets that are met every time, but we will have patients who never receive quality care. Next slide, please. The sixth problem is that we have uncoordinated demands, intervention structures, processes, all coming down to the same facility. Why? Because we as managers are working in silos. We create our programs in silos and we deliver them in silos. However, they all come together at facility level. And so we do not help those at facility level to integrate. We do not help those at facility level to prioritize. We do not help those at facility level to know how to implement the big, fat, fancy clinical guidelines that we provide them. We leave that to them. And then we would sit back and wonder why implementation is so haphazard, why there is so much variation in our implementation. Because we are giving mixed messages, mixed priorities, and we are not focusing on the how of implementation as managers. Next slide, please. Number 7, our workforce is disengaged, frustrated, and unsupported. Next slide. Ladies and gentlemen, I think that this is a major problem that we are dealing with. If we look at the graphic that's in front of you now, you would think that that's just a stupid horse or a stupid donkey. Why on earth can't he just walk away? Why is he standing there? And he'll keep standing there until his owner comes and takes the leash and gives him another direction in which to walk into. I believe that we have learned how to respond in our health systems. I believe that our healthcare workers in facilities have learned what to do and what to say. And so they have become disengaged from any sort of improvement, because improvement requires us putting ourselves out there. Improvement requires us letting people know that we have problems. Improvement requires that I must do something differently. If we have learned that our protocols are keep quiet and do your job, if we have learned that if I show problems, I'm going to get penalized, or I'm not going to get a gold or a platinum status, then I will keep quiet and I will do what is expected. And so we've got a problem in that we have not engaged our healthcare workers correctly. They are sitting with a wealth of information that can help us to change the way in which we operate. They can find those inefficiencies. They can find the waste. But we haven't equipped them properly, we haven't engaged them properly, and their voice is not heard. Next slide, please. Each of the healthcare workers in the health system represent a different part of the health system. If I had to ask those who are, you might have seen this sort of meme before, it's a bunch of blind men who have been asked to describe the thing that they are feeling, and all of them are describing what they are feeling in good detail. But you see, we can't operate in that sort of silo. If we were to create an intervention for this elephant and we simply thought that it was a rope, would we be meeting the targets, our outcomes that we needed to? Would we be feeding the need of the elephant? No, we wouldn't. And so the same happens within our health systems. When we only take in certain accounts, when we only consult with certain cadres of staff, we do not get a full picture of exactly what is happening in our health system. The problem with that is that we create interventions around some of those siloed parts of our health system. And therefore, that intervention is not going to speak to the real problem and to the real situation. Next slide, please. Next. So, ladies and gentlemen, we have a leaking bucket. We have a crisis. It's our health system. We no longer need to wait for that crisis. That crisis is up to us to address. Next slide, please. We cannot keep bringing people into our health system and then losing them from our health systems. We lose them to death because they haven't received the correct care, and we lose them because they don't want to return because the service that they received was so poor. So what are a few suggestions? How do we make this drastic shift that we need to make? One, we must see our health system as that, a health system. We need to begin to work in processes. We need to define processes. We have tools, numerous tools, in the science of quality improvement that will help us to do this well. Quality improvement must be designed into our health systems. If you want quality, design quality into your health system. It's not going to happen instantaneously because people feel passionate about it. It will not last, and it will not be integrated. We have to seek standardization. I cringe very often when I hear people keep talking about innovation. I believe we've had enough innovation. I believe we need standardization in our healthcare. We need to be able to ensure that we are doing the basics right. How often? Every time. For every patient. We cannot just have patients come in at night, receive inferior care, come in on Wednesday morning, receive great care, come in on the weekend, not even be seen. We have to find standard ways of working across our disease portfolios. We must use data differently. We cannot simply report on it and think that our job is done. We must use ways to help us to understand how our system is functioning so that we may respond to our system and not just report. We must create team cultures so that people work together in understanding the health system and in delivering the health care. Our data capturers, our counselors, our clinicians must work together, or else we are going to get a very siloed approach to health. We must create cultures as managers that embraces learning, that makes learning critical, and so therefore we must create cultures of ongoing learning where people feel safe to express the problems, to identify the problems, to bring them to the surface, so that learning is key in order for us to address problems. And we must not think that training is going to fix it all. Training is a starting point. We need ongoing support within the health system. Through mentorship, through the design of tools that help and create prompts as we work in the health system. Training is not the be-all and the end-all. And we have to bring the patient's voice back into healthcare. They know what they need. They have a right to a choice, and it is our responsibility to give it to them. Next slide, please. Next slide, please. So, in the nationwide QI approach that we have adopted in South Africa, we have adopted a framework called the 4A lens. The 4A framework, which attaches a quality improvement lens to all our work. And in essence, it is about do not do anything until you understand the current situation. Do an assessment. When you have done a current assessment and understood why it is happening, the causes, only then should you be acting. Once you have acted, you must analyze. Often, this sort of analysis is only done when we are doing PDSA cycles. That is a mistake. We must help people to do this drastic shift in that assessment, and acting and analyzing is part of everyone's work. And that once we have found things that work, we must anchor them into our system so that we stop reinventing the wheel. We must attach an improvement framework to all work and not just to quality improvement projects. Next slide. So, ladies and gentlemen, it is now in our hands. We have a crisis of healthcare. Each of us sitting here today represents millions of patients that are relying on us to get it right. We must make that shift from just being disease-specific and from just treating diseases to focusing on the system in which delivers care to all of these people. I hope that you will join me in being advocates for the new crisis. That as you sit here over the next 2 days, that your mind will be open as to how do we shift how we work, how do we create a health system, because our patients need it. We are failing because we are not doing it. And quality improvement and patient safety is our absolute responsibility. Thank you very much for your time.
Okay, another round of applause for Lauren. Thank you very much, Lauren. You've really nailed it. You've given us what ails us. You've actually done an assessment of where we are, what we are not doing in Africa. and you've given us a way forward on it. And I think after this, maybe we can go into group work so that we can now we look at those things and come up with a plan of action so that it can help Africa to move in the trajectory that is required in quality improvement. Otherwise, thank you very much on that. So let's, we've looked at what are the issues from fragmented quality improvement initiatives, people doing QI in their own corners. We've looked at a number of issues that have been laid out, the data for driven, data for improvement, and I like the idea that people do work. We also need to improve the work we are doing, and that's what needs to be embedded in what we do. So that one has been laid out for that. So before we move on, I would like to invite a panel just to discuss these issues that have been laid out as a discussion. So probably on the stage, I would like to have the following come into the stage. We have Olabisi, Dr. Olabisi Ogunbashe. Is she around? Yes, welcome. Let's have Tumi Divine, Dr. Tumi Divine, if she's around. Dr. Tenza and then Dr. Elom. Kindly come forward. Let's have a discussion panel. And also, I don't know whether we still have Dr. Irungu. So probably as they come in, I'll just quickly introduce them, who they are. So Dr. Irungu, who is online, is a distinguished medical doctor, renowned for his pivotal role in advancing patient safety and initiatives in Africa, currently serving as the head of patient safety unit in Kenya, in Kenya's national level, and he holds the esteemed position of national IPC and patient safety focal point. So that is Dr. Irungu, who had spoken earlier. Then the next person I'd like to introduce is Dr. Olabisi Ogunbashe, who is just, maybe you can raise your hand. She's the lead quality improvement mentor at the Lagos State Health Service Commission in Nigeria. She's a pediatrician and director of clinical services and training at the Maternal and Child Center, AJA in Lagos. She has obtained the Society for Quality in Healthcare in Nigeria certificate in quality and patient safety, among other areas that she has done. Then I'll go to Dr. Sabelile Tenza. Maybe you can raise your hand. She holds a degree, hold a PhD in public health system and policy from University of Witwatersrand. Currently, she is the senior lecturer at the School of Nursing Science, Northwest University, lecturing in research and research methodology. Then we have Dr. Tumi Divine. I don't know whether you can raise your hand. Yes, he has a passion for quest for quality brought to him through IHI and then Acquire Africa. And he cares in affordable but still meeting international standards is hard to come by in his area. And survival rate for many diseases is too wide depending on which part of the world is present. Those are the beliefs that Dr. Tumi has. Then we have Dr. Elom Otochi. Yes, Dr. Elom is passionate about improving quality of care and patient safety outcomes. In view of this, he has had the opportunity to work in various capacities with various organizations, including Africa, IHQSA, WHO, UNICEF, and other undertaking research and so forth. So those are my panelists. And I'll be asking them just to give us to give us the county experience perspectives. What are their, maybe we could be having unique aspects that are there. So I'll start with Dr. Elom, and the question is, are there national framework and strategy policy for quality in your country? And you can look at, just use that one as a guiding, looking at what we have just discussed now. What is your national framework and strategy for policy for quality in your country? Welcome. Maybe we can be assisted by, it's not working, but maybe you can shout as we fix.
Strategies and frameworks as far as institutionalizing the concept and practice of quality in those countries are concerned. Yes, so I mean there are benefits in those country strategies and frameworks because it provides a form. I have recently also worked in a country where there is virtually nothing as far as a quality strategy or a quality framework is concerned. And the quality program is very haphazard and very disintegrated, and you don't see any form as far as quality is concerned. So I think that we would encourage all of us countries to develop those strategies. But one of the things is the development is a box ticked. The other key is how we are able to marshal all the necessary resources to facilitate implementation of those strategies. And personally, I am happy that as a country where I come from in Ghana, there are various efforts and initiatives to ensure the drive towards the implementation of those national frameworks and strategies. And I can also say same for so many other countries that I have had the opportunity to support. For instance, in Sierra Leone developed its first strategy as well, I think just about 5 years ago. Until then, there was virtually no quality program in the country. Another is also in Liberia that has also been implementing their quality strategy over the last 5 years. I hear a colleague from Botswana is in the room, and they are also developing their quality strategy to facilitate the implementation of their national quality program. So I think that is what I would like to say in brief for colleagues to also add. Yeah, over. Thank you.
Okay, thank you very much, Dr. Elom. And it is only by doing that so that we can have a coordinated system, so that we embed quality within the system, not doing it on our own corners. And I'm happy that as Africa, we need to begin embracing coming up with quality and a policy and also a strategy. We've heard that we should not just have audit-driven initiatives where we just comply to standards, but we need that commitment. So as Africa, probably I'll ask Dr. BC, what is, do we have national quality standards in your country? And
thank you. Greetings, everybody. I'm from Lagos, Nigeria. Yes, we do have quality standards. And in Nigeria, the quality drive really, I would say, started from Lagos. And it started in 2015, where we had the Health Service Commission bringing in a non-for-profit. That was the Health Strategy Development Foundation. So they came in with a National Health Quality Initiative. We call that NHQI, National Health Quality Initiative. So they had this framework to start quality improvements in Nigeria, in Lagos in 2015. And the journey has started since then. And a lot of successes have been recorded. Trainings, learning sessions, you know, of the secondary public health facilities, some private and some primary health care centers. So that was where QI started for us, and the interest and the passion. Because before then, nobody knew what Q, you know, I'm doing pediatrics, you are doing O&G, and everybody is just walking. But when QI came, it just opened a new sphere of, yes, you are walking, but are you walking well? Are there tools, are there systems that you can use to drive your work even better? Are you focusing on the patient? So that's, that newness in looking at your work started, and we've achieved quite a lot, to the extent that other states, we have 36 states in Nigeria and the Federal Capital Territory, ministers of health, commissioners of health are now coming to Lagos State to see what is happening with respect to quality. So we are taking them through the facilities, showing them the projects we've been able to execute, showing them how we have a quality improvement committee in each secondary public health facility, how we operate our meetings, you know, how we execute our projects, you know, so that has been key. The NGO left about 2-3 years ago, and now we're on our own, you know, and usually that's where the system falls. But it's been such a success that we are running fine. The QI in Lagos State is going stronger and stronger. Now we also have another NGO with us, Farm Access, which has brought in the safe care quality standards. We know safe care is an internationally approved standard. So they've gone around the facilities, the public health facilities, and assessed the facilities with the standards, internationally recognized standards. And they've done this about 3 times now, and most of the facilities are now increasing from level 2 to 3 to 4. Nobody has gotten to the highest yet, which is 5, but facilities are improving, so that drive is there, the knowledge is there. But like Lauren De Kock said, we need to go away from QI committee, we need to move on for everybody to embrace quality. So our leaders, they are passionate about quality, but we've started the journey. There are challenges, but we'll move on. Thank you.
Okay, thank you very much, Dr. Bisi. And probably I'll ask Tumi, Dr. Tumi, and then getting experiences from Cameroon. What is the role of the public sector in improving quality of care from your country? You can give your experiences.
Thank you, Director. In Cameroon, actually there is nothing like that. I will say it here. There is no public health sector program or anything for patient safety, for control or assurance that we know of, that usually goes around doing such things. I can tell that in the public hospitals, actually, there are some hospitals that there are armed guards present there. No one will leave the hospital without putting on with a lab jacket to prove that he's a doctor, simply because of the kind of practice they are practicing. The patient clinician relation is horrible. Um, but I want to come back to us as a mission hospital, how we do practice and how do we carry out things. Nationally, there is no such program. There was sometimes that we had, were introduced to what we call PBF, performance-based assist function, that is sponsored by the World Bank, where some doctors go around to assess how they are doing, is the hospital clean, how are they taking care of the patients. Apart from this, I know personally there is nothing exists as public per se. But where I practice, the cultural organization permits us to to improve on our practice, but there is no framework still as quality improvement program present before the coming of Acquire in our institution. So we actually looked for Acquire. Acquire didn't look for us before it was created. I've been practicing for more than 14 years, and my quest have always been to do the best, practice what is evidence-based, quality to prevent all the crisis that was presented by the director initially. So in our hospital, we are some sort of an oasis in the whole country. If a patient has a problem and has not been to our hospital, somebody would definitely advise that person to go to our hospital. This is with respect to our practice and the kind of care we give to them. It is not the best. When the director was talking, actually, I thought about in my country, the patients who run away, who are sick, who try to seek for help in other places, do go actually to South Africa, many of them that I know. But in our hospital, the way we have tried to improve was, sitting and talking with those giving the care, right? The nurses, the doctors, asking them what matters to them, how did they feel at work, how that day went. We assessed this, and it was very welcoming when we talked to them. They were very welcoming in sharing their difficulties, what causes burnout in them. They complained a lot about communication, they complained about equipment failure, they complained about doctors not listening to them when they come to the ward. They complain about late salary, they complain about many things that I will not enumerate here. And then we had this control where we brought boxes for them to have in the ward. In case they are having, these two boxes had two colors. When at the end of the shift, you will slot a color in each of the boxes marked bad a day or a good day. And if you had a nice day, you slot a color in the box that says it was a nice day. If you had a bad day, you indicate like that. So we then went forward to do an intervention for these problems that nurses raised while we talked with them about communications. There, we tried to ask them how will you expect your friend, your fellow colleague to communicate with you that will help you have a good day at the end. This proceeded, we went several times. We also intervened by talking, we had a small teaching about communication. We talked to the administration about visiting and sitting and talking with them as such to be welcoming. And we followed how their day was changing. We followed how they were slotting, and we had some information. We thought, and they said to us that it was helpful what we did by intervening and trying to assist in what could help them make their day better. Quality care is still a far-fetched thing in my section of the country, and that is why we are here to learn. And you know, as you are moving forward, you hold your brother's hand. This has been many countries in the West have worked on this for years, and probably now is to hold our own hand as we move forward, improving on quality care. Thank you.
Welcome. Thank you very much. You are in the right place, and as Africa, we came here so that we can share experiences from one another, see where you are, and you have given us a good area that on experience of care, or what we call positive experience of care for the clients, and you are doing it well. I like the idea of you having suggestion boxes and getting to know were they happy. So we have tools around that some of us have explained. On in our keynote address, we were taught about. We looked at. It highlighted the issue of dimensions of quality. Is it safe? Is it effective? And so forth. So for Dr. Tenza, from your experience, I don't know, have you done accreditation of health facilities? Does your country, or if you are from hospital-based, is accreditation improving quality of care for the facilities of where you're working? So probably you can speak around that topic. Welcome.
Good morning, colleagues. So thank you for that question. I'm from South Africa. I'm based at the Northwestern University and supporting the hospitals. The question is on accreditation. So I'm lucky that I'm speaking after Lauren, who's given you, who drew from our country in most of the issues that she dealt with. And most of you colleagues, you know about COSASA, which is an accrediting organization. But in terms of the legislation, we have Office of Health Standard Compliance, which is the regulatory body, which is also responsible for accreditation of all hospitals in public and private sector. So the Office of Health Standard Compliance, it sets the minimum norms and standards that needs to be met by the hospitals for them to be able to be to be accredited. That process is taking place, but I think when I was listening to all this conversation, I think our challenge it's the fact that in South Africa we have policies that exist. Our quality improvement policy was done in 2007. So if that policy was implemented since 2007, we would be more far ahead than most of the countries. We have a different view if you look at things from the top and those who look at things from the bottom. There's a different view that you'll get if you were to see things from the top. If you see things from the top, you would see so much compliance with everything that you see green, like the picture that Lauren showed. But if you're looking things from the bottom. We did a study published early this year around March, me and my team, on the perceptions of nurses on the quality of care. Specifically, we asked one interesting question: if they would refer their family members to the hospital where they work. And that was a very interesting, that yielded very interesting results, because very few nurses across the whole nation, that was a national study covering all the 9 provinces of South Africa, and at all different hospital levels, from the district to the tertiary hospital. And that study found very few nurses confident on their hospital, on the quality of care and safety delivered in the hospitals where they work. So that really gave me such a shock, and it unveiled that even though you would see we have the national core standards assessments, which then give you good results, or you have the ideal facility, which is a national-wide quality improvement approach to improve in line with the national core standards. But when those assessments will show you very good reports. But when you get to the ground, you realize that there is a disconnect between what you find at the ground and what it's viewed from the top. I think that is very important for me to address. And in line with that, there is quite a high level of poor support to the leaders at the front line, and a lack of empowerment of the frontline workers. I don't think frontline healthcare workers, even though they intend to improve quality, but they know how to do it. I think they are stuck there because they are more oriented to the tick box procedure to get compliance, rather than to embed quality into day-to-day performance in their day-to-day doings. Thanks.
Thank you very much, my panelists. I know there are those who are online, and I don't know whether there are questions that have been put on the chat. And if there are 1 or 2 questions, you can just ask. For those who are here physically, do you have any 1 or 2 questions? And then we ask the panelists. But I'll also, I don't know whether is Irungo in. I know you had already given your input, but if a question arises from that, yes. So, okay. So let's have 2 or 3 questions, and then if you are online, you can unmute and talk.
Yeah, I just wanted to share a few thoughts on some of the comments that have been made. I think the bit on standards, I think it's a key thing. That it's one of the key things that can eliminate variation in the care that is provided. But I mean, standards often, in most countries, standards are often input-based and not very outcome-oriented. So if we should be using standards, then we should be thinking outcome and being outcome-oriented as far as the use of the standards are concerned, because it becomes very basic. And then also the issues of our processes and what we are doing to arrive at that destination that is talked about. And the role of the public sector as well, I think. And here I want to commend some of the countries that there is a deliberate public sector effort to support public sector to get their facilities to be providing quality of care. And I was fascinated again in Botswana, where government is using public funds to support public facilities to reach accreditation. And some facilities in Botswana, public facilities, have COSASA accreditation, and it was very fascinating. You go to Rwanda as well, and there are public hospitals that also have COSASA accreditation. And in your own country here in Kenyatta Hospital, you have ISO, they are ISO accredited, ISO 9001. which is very fascinating. Oftentimes you see the quest for accreditation often being driven by private sector. So where governments are committing public funds to support public facilities to also ensure the drive for quality, I think that is very worth commending. In Ghana, there is we call them the CHAC facilities, our Christian Health Association facilities, that are also safe care accredited. They have various levels of safe care accreditation. So I think the public sector is key, so that quality is not only seen as a demand or seen only in the private sector facilities, but where most of us, anyway, maybe most of you in the room might not go to a public facility when you are sick. But where a lot of the general populace would go, I think that quality should be enhanced. And I was fascinated about his research work. And I did a similar work in one of the facilities. 5 obstetric nurses were on duty. These obstetric nurses were at various levels of gestation by way of pregnancy. And I asked all the 5, if you are due, would you like to deliver in this hospital? If you are due, would you like to deliver in this hospital? And your guess is as good as mine, what the answer was. Of the 5, none of them said a yes. The only person who said a yes was only one person who said a yes. And it was a yes with a condition. And the condition was that, hey, Elon, I would only like to deliver here if my team is on duty. Otherwise, all of us who are, the food we are cooking, none of us wants to taste the food. So the question is, who are we cooking the food for? Anyway, I think that is something we may have to be finding answers to as far as the discussion is concerned. Thank you.
Okay, thank you. Yes, there are 2 questions, but maybe who can run with the mic? So we have 2 questions, and then we can answer that.
Okay, good morning. Yes, my name is Ruth. I'm from Botswana, Aurum Hospital. So I'm from one of the accredited hospitals by COSASA, and I'm happy to say that. So my question goes to Dr. Tenza. Yes, you said that you will find that you have good results, you sometimes see the good results, but you will find that on the ground is something else. So to me, it's something to deal with the mindset change. So how can you maybe assist the staff or the people maybe to work towards their mindset change in them towards quality? Thank you very much.
Okay, let's take another one, and then we can ask Tenza to take.
Good morning, everyone. Yeah, my name is Dr. Herbert Nzeke from Uganda, specifically from St. Therese of Lisieux, River Health Center 4. My concern goes to Dr. Tommy. When you talked about performance-based functioning, where the public sector, the private sector is still doing it and trying to come up with it, and yet the public sector is not yet there. In view of that, in Uganda we have what is called a result-based financing, which cuts across both the public and the private sector. But like we are saying, like Lauren said, these are people who are just focusing, most of the facilities are focusing on targets and don't really look at the deeper things down there, how the systems are working. And they are meant to say, if our target is 20, we have hit the target and so we are there. But we're not looking at systems. How is Cameroon doing it in terms of your performance-based functioning? Which strategy have you put to make sure that you're dealing with the functionality and the systems in regards to this? Thank you.
Okay, thank you. This performance-based functioning is a group of doctors and administrators that has been taken out of different institutions. They go around to rate what is happening in the hospital. I have seen them, and I've read their results. But they have to get the permission from the hospital before they assess it. And there was one time some hospital refused their, didn't give them access to their hospital. So they go around and evaluate these factors, and then they try to educate the leadership on how to run the hospitals, the things that they found that were not pleasing, and how they can change. This is what I know about this group. I don't know if it answers your question. Okay, thank you.
Thank you so much for the question, which you drew it from my comment about discrepancy between what you see from the top and what you see from the bottom. So you asked me about what can be done to deal with mindset change, right? So there are several things that can be done. I'll just share with you, colleagues. For example, in South Africa, you will see one, it may be happening in other countries as well. You'll find one healthcare provider working, maybe employed in government hospital and doing moonlighting in private sector. The same nurse, when you see, you may receive substandard care from the same nurse, perhaps attitude problem from the same nurse in government. When that person goes to the public sector and you meet that same person, you will see a different shift of attitude. So I had a privilege recently to speak to hospital leaders, and one of my talks are around stopping to work for the government or private and start working for yourself and account to self for what you are doing. Because then when you stop working for somebody, then you stop creating a reputation of somebody. You start working for yourself and you create a reputation about yourself and around yourself. And that influences a lot of mindset change. Because if you work for somebody and that you have expectation from that somebody and that person doesn't meet expectation, then your reaction depends on your expectations that are not met. Then it's lack of sense of ownership. So that speaks to the organizational culture. I'm busy doing an ongoing study on patient safety culture, but some of the things that are coming out, they reveal a lot around organizational culture. That people, they want to comply so that the manager doesn't see, or so that it's comfortable for that particular person. So organizational culture is, if we get to where people know they can, firstly, healthcare providers can separate between problems that they contribute themselves to and problems that are system level, and they are not at fault, but the system is at fault and they need to be supported. Because people, they are running away being scared of things or of facing things that they are not even the ones who made those things to be like that. And that is speaking into system level challenge. The other part that will help with mindset change, most of quality improvement and safety leaders, specifically, it may not be like that in other countries, but in South Africa, I know that there are the positions. We have a very good structure from national to the facilities. There are positions of quality, there are posts of quality. that there's somebody responsible for quality. But not all those people have been trained of what is the responsibility, their responsibility to that office. If you look at our training from the medical school, we have not embedded quality improvement and safety in the training of medical healthcare workers, and we expect them to adopt this quality improvement and safety when they've already been endorsed as practitioners. It's very difficult to pick new culture afterwards when somebody have given you all the awards that you are already a healthcare practitioner, you are a doctor, you are a nurse, you are professional, you are good to go. I mean, you've gone through the whole training until the end, and there was no mention of this thing. And later you tell that same person this thing is important. So I think we need to go back to the drawing board, and I call it was our quality improvement ancestral era that now us, in our generation, we need to start influencing medical education, that it includes modules that focus on quality and safety. Then we won't have people who become qualified without seeing the value of quality and safety, which will then change that mindset from the beginning before they qualify. Thank you.
Okay, before I give ABC and Dr. Aisha to talk, let's have just some comments from the online, and then.
Thank you, Doctor. This is not coming on. Oh, well, you're hearing me loud and clear. I'm going to be the face of the online community. This is a genuine hybrid meeting, so we are just about to give Caleb Kiplangat and Jolade Odedoyin a chance to speak. But as they are working on giving them the chance to speak, allow me to just talk about the comments. Dr. Lauren, they're saying excellent presentation, very informative, an eye-opener for the quality improvement in healthcare. Now, allow me to then ask the questions that are on the chat. Ken Limo is asking, are there QI support groups and mentors where starters can be supported? Someone else is asking, can they expound on the outcome-oriented versus input-oriented assessment? Martha Awiti asks, what are your key messages to our African governments on steps that can be taken to support the global goal of improving health and reducing health inequalities? Someone else is saying it is important it's not just important to understand COSASA accreditation and understand that it's about peer review. We need to move on and figure out how to reach excellence in our systems, rather than a punitive, legalistic approach. Olawale Gidado says, this is for Dr. Ogunbase. You mentioned moving on after the NGO left 3 years ago. How have you been able to sustain the improvement or the learning from HSDF and ensuring QI in the health facilities? Maybe, Tevin, are we ready to hear from Caleb and Jolade? Karen Kiplagat, sorry. So, you to talk, please just go ahead and talk. Karen Kiplagat? You need to unmute yourselves. So maybe if you're not able to unmute, we will just move on. Okay, go ahead, Jolade. Q Jolade, your point is heard loud and clear. Let's stop our siloed working. Just to let you know, there's 227 people online. I was right. The people outside are more than the ones in the room. Let's get some solutions going. Back to you, Dr. Kangdi.
Okay, thank you very much. I'll give Dr. BC and Dr.
Thank you. Maybe just a comment to my co-panelists, what they have said. The issue of mindset and attitude, it's big in our continent, and it's something we need to address. The so-called, the developed world, you can't just behave anyhow, you know. There's something expected of you. So, Dr. Tenza, I like what you said about working for yourself. What are my own standards? Not because I'm in a public facility or what. So her question about mindset has to be taken by all of us. You know, irrespective of what we are doing, how are we treating our patients? In fact, recently, just a few days ago, I was speaking to the director of a private hospital, and in their facility, they don't call patients, they call patients guests. And when you call patients guests, it just gives you a different, you know, a different mindset, you know. We've gone away from patients to clients, and now they have taken it a bit forward from calling their patient clients to calling them guests. And I really took that on. So in the government sector in Nigeria, it's a big problem. What she said about mindset. So we have this initiative to go strong on fixed mindsets and growth mindsets, training CMEs and posters all over the place on fixed mindsets and growth mindsets. There's a lot about it. We don't have the time for that. So whatever you're doing, your work relating with your clients, are you changing? This is the way we've done it, that's how it's going to be? Or do you have a growth mindset to improve on what you said? And then he said something, my co-panelist said something about accreditation bodies being funded by government. Yes, that's good, but we must move away from there. Because in Nigeria, one thing we found that we have what we call the HEFAMA, that's the Health Facility Monitoring Agency. One of the challenges they have is the reports they get from when they visit private facilities. And they are hard on them, you know, because they are for licensure and also for accreditation. So when they go to private facilities and they don't meet a good standard and they, you know, they give them whatever don't let me use the word punishment, or the recommendations when they meet those poor standards. Those private facilities tell them, when you go to government hospitals, are you as hard on them as you are on us? And then the challenge is the government funds these accreditation bodies or these monitoring bodies. Are they going to be so firm on government facilities the same way they are on private facilities? So we must move to a level where our accreditation bodies stand alone, have their own funding, and are separate from government, so that there's no bias when they now come to executing their work. So straight to my question now about mentoring. I wouldn't want to dwell on that a lot, because the organizers of this program have seen that it is key, and they have built a session around coaching and mentoring, which we are going to have tomorrow. But the question put to me is, when the non-for-profit left, that was the HSDF, how did we stand? How are we standing today? Because we all know that's when programs collapse, when the funders leave. But like I said earlier, they had a framework, they had an initiative, and they were passionate about it. Apart from our teachings, they used to come to all the facilities in the collaborative, stay with us in our QI meetings, ensure we're talking data. Because without data, there's no QI. not just discussing problems, because at the end of the day, what you find is there's no this, there's no that, this problem, that problem, and time has gone. So you must be talking data, you must be making decisions, you must be talking projects and all that. So we had that hand-holding by Health Strategy Development Foundation, and we had the framework. Every public hospital in Lagos State has a QI committee. Every QI committee has leaders. QI lead, data lead, improvement facilitator. Every government hospital, it didn't start, or we started with about 11, and then we started adding. Now, out of the first group that were taught, we now have mentors who handhold the new QI committees coming in, you know. So we now mentor them, and we go to the facilities. We do what the organization did to us. We also join their meetings, we encourage them, we lead them, we guide them. But most importantly, I must say here is, all the QI committee leads and mentors, we have a committee. We have our own leaders committee. And in our leaders committee, we take on the issues. You know, we have our monthly meetings, we take discussions around QI, we look at our challenges, and you know, we focus on them, and we see how we can do that. And then we have what we call cluster groups, because how has the program not collapsed? That's the question. We have focus group. We divided ourselves into like four groups. So in each group, we can have like 7 hospitals, public hospitals, you know, and in those clusters, you also have your meetings. So you can't hide, you can't but do projects, because you are going to come to your cluster to learn together and to meet together. So what are you going to present if you don't do the work? So yes, it's been a growing and a learning curve, but we're standing strong. We're influencing other states, Yobe State, Niger State. You know, they're seeing what is going on, and I'm not surprised, because when COVID came, big men, you know, government officials, they were coming to Lagos State, and it's not because it must be because of a reason. So it's important that Lagos State stands, but Lagos State cannot be a silos, like the director said. We must influence, and that's what we're trying to do in Nigeria, and see how we can take QI to other states. Thank you.
Thank you very much, BC. And I would like to pose a question to Dr. Aisha. As we have had fragmented quality improvement initiatives, what is the experience in Kenya in terms of harmonizing to ensure that quality is done within the system?
Thank you very much, Dr. Kande. Good morning, colleagues. My name is Aisha Mohammed. I'm standing in for Dr. Irungu. We work in the same directorate. So in terms of the quality of care in Kenya, we had noticed a few years ago, actually many years, that there are very many initiatives, but these are, you know, in silos. And what the country did is developed a quality of care certification framework, which we launched in 2020. And I think Dr. Irungu mentioned this during his presentation, but just to elaborate, that brought together a mix of regulation and quality improvement. So in terms of regulation, we developed a tool that brings on board all regulators to work within a joint system. So this will then look at the minimum patient safety standards and make sure that there's compliance to those. And then if you have reached a certain point of compliance, then you are onboarded for quality of care improvement to move towards accreditation. So the country developed what we are calling Kenya Quality Model for Health, fondly known in the country as KQMH. And I know Dr. Irungu mentioned this during his discussion. So the KQMH is, I know doctor here mentioned that it's good for you to have an external accreditation. But what we noticed in the country is that we have many public facilities that are not on board, and accreditation is quite expensive. And we also noticed that the private sector, in as much as we always assume that the private sector does well, we have so many low-level facilities like, dispensaries, health center level in the rural areas, which are private facilities that are also doing very poorly in terms of quality of care, and they cannot afford accreditation. So the country developed the Kenya Quality Model for Health as a platform to help government facilities and resource-restricted facilities to start the journey of quality of care. And through this quality of care certification framework, we rolled it out across the country. We have 47 counties in the country. So we trained the county level, the county health management teams. We trained quality of care coaches. We have like 3 quality of care coaches per county that are actually trying to mobilize this. And on top of that, we tried to link quality of care through this certification framework with the social health insurance of the country. So that if you want to be on board the social health insurance, then we expect you to be on board quality of care initiative, and should be evidence for that. Thank you.
Thank you very much, ladies and gentlemen. Because of time, I can see one burning hand. Maybe we give you just give us one to make a response. Thank you. Welcome.
Thank you for the opportunity given to me. My name is Ajayi Abimbola from Nigeria. I just want to appreciate the laureate. Thank you so much. It was an eye-opener, and I could resonate very well with all that you highlighted as a problem. And you said something. Do not do anything until you analyze the situation. That is key, and that is why we are here as Africans. We are like a big family trying to achieve the quality of care in that our patient. Patient is at the center. So mine is like a comment and not a question. So I just want to say that having accreditation is not the ultimate. What is the patient experience? We as healthcare provider, we cannot appraise ourselves. You cannot judge yourself. That patient that is at the center of it all, because everything that we are doing to achieve quality is still centered at that patient. The relative of the patient, what are they saying about our deliverables? So, just like one of the panelists said, that when you look at it from the top, it seems good. Most accredited centers, if care is not taken, sustainability is always a challenge. You can get accredited, but if you don't pay attention to little details, just as she said, we might not achieve it. And problem not identified can never be solved. And it's about our value system. How do we value quality improvement? Fine, we are talking about standard. That we can't throw standard into the bin. What are we doing as Africans to ensure that our people work as a team to adhere to the standard? Fine, quality improvement is about bridging the gap between your target and the ideal. But you cannot throw away standard too. Why? Because your standard will ensure that that patient is safe. You have your protocols. So the quality assurance aspect of it must also come to play. So we need to value it. And when you value something, you tend to strive to achieve it. How then do we encourage our team? Not working in silos this time around. How do we ensure that our team value quality improvement? Because whatsoever you don't value, you cannot put in your effort. So as Africans, we must ensure that we inculcate in our team, because together everyone achieves more. We can't afford to work in silos, but how do we bring them on board? That is key. Sustainability is very, very, very key. She has given us a shift, and I just want to dove my hat cap for you, because I have been in this, I've been an advocate of quality improvement, because it pays off. Without it, we cannot deliver. Our deliverable will be nothing in the sight of that patient. And the patient experience, just as one of our panelists said, if you are asked to be a patient in your facility, will you love to be there? Why do you want to offer things that you cannot, that you cannot, categorically say that, oh, I'm comfortable with? Most of us are not comfortable with working in our system, as in accessing service in our system. Why? Why do you want to give to others poisons that you cannot take? So we need to inculcate it, and the system processes is very key. Seeing our healthcare system as a system, not working in silos. The quality design, just a little change, change idea can change the narrative of our deliverables. The take home that she has given us, the 6 take home, data for improvement is key. Without data, you cannot make informed decisions. And I can say here, without missing my words, that there is no need for us not to copy ourselves. Just like my permanent secretary always says, if something is working for me as a facility, then other persons there can copy shamelessly. You only need to adapt it or adopt it, tweak it to fit your own system. Why? Because 2 systems can never be the same. So coming here, for us to achieve that purpose, we need to be intentional, we need to focus, and we need not to do it as an academic forum. But what is our take home? And by the time we adhere to our take home, I will see African continent moving higher from the base of the ladder to that desirable place in terms of quality. Thank you, all our panelists, and Dr. Lauren. I salute your courage. I love your presentation. Brilliant presentation, and I'm impressed. Thank you.
A round of applause for that, for her. Thank you very much for summarizing and giving us ideas on what we need to do. And I've picked up one thing. One of the big ideas that we should take from this meeting is that we should ignite for demand for quality, so that our clients, as they come to our facilities, they put us on our toes to provide the very best, so that we can provide what you're talking about, the patient experience of care. So I would like to give my panelists just half a second before, so that they can just say a closing remark or one thing they picked up from here. So I'll start with Dr. Elo. You can start from your side.
Good morning again, colleagues. So for me, I think that what came up from the online participants, outcome versus input-based assessments. And I feel this is a good discussion we should be having. There has to be a balance, however, because currently, I think I can speak for almost all African countries, that currently we are still input heavy. We are still not doing so well in terms of the inputs we are having in our facilities. So in as much as we really want to do output-based assessments, we also have to make sure that our inputs are in place. We have to make sure that our processes are working well before we can really do a proper assessments on the outputs. So in Kenya, we are trying to balance that. Our quality of care platform actually looks at inputs, processes, and then discuss the results, but we are still ish in terms of the results, because there's still a lot to be done. Thank you.
Okay, thank you. Dr. Ibis?
Thank you, sir. Yeah, so for me, I think I'll just like to introduce something we've not said all day, and that's the universal health coverage. Africa has the highest burden, of loss of diseases and illness. So we can't but take quality improvement on, And in talking about universal health coverage, we have the population. Our statistics are nothing to be proud of. We need to come together. We need to instead of competing, we need to collaborate with each other. We need to look into our service coverage indices. We need to look at out-of-pocket spending, because that is the issue. We need workable insurance schemes, that are not just policies, but that are implementable. We need to bring our people out of poverty, out of ill health, and like the coordinating minister for health and social welfare in my country said, Professor Mohammed Pate, he said quality improvement is a pivot that will lead to transformation of our health systems. So I believe that, and that's just it. Thank you very much.
Dr. Tumi, holding one another.
Okay. Thank you. One thing that is important is all of us who are choir, who are here present, and others online, and others who did not join, is first of all improving on ourselves and making sure that we are doing what we are saying. I think that is the most important part of it. So that we don't say something, we don't hear something, but keep doing same. That is something that I've been practicing for quite a time now. I make sure that my communication is good. I make sure that I receive my patients well. I make sure that if I am to write a medication, I write it properly. I make sure that it is well given appropriately. Sometimes I laugh to myself that I am at home, but I'm calling back the hospital. Have you given back that Have you given that medicine to the patient? How did you give it? How is the patient doing now? I'm at home, 11 p.m. I'm calling the hospital to make sure that what I think about the best care is correctly administered. That is, we are assuring and following up to make sure that just us, maybe a drop in the ocean is an effective drop. In that manner, we will help stimulate others to follow, and the chain will keep growing. And why not? At some time, we will be at a position far, far higher than where we are right now. Thank you.
Thank you very much, Dr. Tenza.
Thank you very much, moderator. Colleagues, my final remarks as I'm seated here, carrying the patients from South Africa, specifically in the districts and the province, Northwest Province, and the hospitals which I support. I'm reflecting as we are having this panel, and I'm still realizing that healthcare providers are overwhelmed. Nobody leaves their houses to go and deliver poor quality of care and care that is not safe intentionally. There are things that are responsible, or are not responsible per se, but contributing factors that perhaps we may want to pay attention to. And quality improvement has been assigned to offices, and it has made to be a problem for a particular office in hospitals. And that is one thing that is very wrong that we have done. And in that case, people have adapted to that status quo. And we need to do something about that to redirect their mindset, as we said before. But human resource, there is a lot of decrease in human resource, in staff shortage in hospitals due to different reasons, and that creates a burden over the people who are actually compliant on being employed or being on duty. And that leads to a lot of demotivation. I think we need to devise strategies to deal with demotivating environments. How can healthcare providers who are willing to run the race reignite their passion, given all the situations that they are facing? Because we cannot say we're going to run with them with all the training that we are doing. Those who have supported groups who are doing the quality improvement course, they know how, they've learned how much people have willingness to do, but there's so much support that they still require. So there is a lot. In South Africa, by early this year, we were sitting at 77 billion rands litigations. So how do you tell a healthcare provider who's overwhelmed with fear of the next litigation, if it's not going to be on her to be motivated to work? The environment is not psychologically safe, the work environments for the healthcare workers. I think I would have liked even the acquire course, if it could tap, or we can find a module, an online module even, or even a Zoom module, Zoom sessions that tap into improving motivation for healthcare workers across Africa. And I think that will really link their newly found motivation to embedding quality improvement or improving their work every day. It will find an expression on how we get them to improve their work every day, because you can't be demotivated and you are asked to improve anything. Thank you.
Thank you very much. Then lastly, we have Dr. Aurum, your final thoughts.
Yes, thank you very much. And I think this is in answer to one of the online responses, a key message. So one is, for me, on regulation. I think we would have to strengthen our regulatory bodies, facility regulation, and then regulation for the human resource. I think that is very key, and also make our regulatory bodies a-bias and as much as possible also apolitical. Because oftentimes you go to a number of our countries and our regulatory bodies are very hard on private providers and very soft on public providers. And the question is, you are using the same standard of measure. So why is it that you can be confident to close a private facility, but you are reluctant to close a public facility? So we'll have to be using the whip of regulation and apply it a-bias. We should be a-bias and apolitical when it comes to regulation. The other bit for me is about strengthening the demand side of quality, and which is the general public and the populace. So we educate them and we empower them to demand quality whenever they go to the health facilities. I think if we are able to do these two, our health care workers, with respect to all the emotions that Dr. Tenza has spoken with respect to the difficulties that that confront healthcare workers in the work environment. I believe with these two, we should be able to sit up so that in spite of the difficulties we find in our work environment, I mean, this is the oath we have sworn, isn't it? To do good to all men, to provide care as safe as possible to all men. And when we were swearing our oaths, it was without the predicament and the challenges in the work environment. So we should be able to do this, strengthen regulation, and empower the communities to demand quality. And finally, my sister said we should copy, and copy shamelessly. But I also add that in our copying shamelessly, we should also acknowledge where you copied the learning from. And this is somebody wearing an academic hat, because innovation is very difficult, and going through an innovation process is very tedious and very painful. So if you see your innovation and your practice being replicated elsewhere, it is exciting, but let us acknowledge where you copied that innovation from, and we continue to encourage the innovation within the continent. So thank you very much.
Okay, thank you very much. So I would like to take this opportunity to declare that we have now a time for revolution for Africa, so that we can institutionalize quality of care in the health system and encapsulate all what has been said from this panelist, including our guest speaker, who did a very good job this morning. So let's give, allow me to give a round of applause to my panelists here. And thank you very much. So I'd like to declare that we go for tea and come back after 30 minutes. That is approximately, we come back at 12? So let's come back at 12 because we are a large group. So thank you very much. Those who are online, we are taking a break. Although there is a